So teletherapy, in teletherapy, we are using electromagnetic radiation or particulate radiation. Electromagnetic radiation may be gamma rays or X-rays. The source for the gamma rays is cobalt-60 and source for the X-rays is the LINAC machine, linear accelerator. In particulate radiation, we are using electron beam or proton beam. So out of these two, gamma rays, that is cobalt-60 or LINAC, which is more commonly used? X-rays. So first, in teletherapy, we'll see that cobalt-60 and LINAC. Why this is more commonly used? In case of cobalt-60, this is emitting gamma rays, and these are nothing but nuclear disintegration. These are nuclear disintegration. In this case, we have no control over the disintegration. It means whatever the half-life T half, suppose this is 30 years, then this cobalt-60, it will keep on emitting the radiation for 30 years. So there is no control over integration. After 30 years, when the half-life is over, it will stop emitting. The second drawback with this is, first is no control over this gamma emission. Second is, we cannot control energy of the gamma rays. We cannot increase the energy or cannot decrease the energy. Suppose we want to treat these two tumors. One is near the surface of the skin. In this case, we want gamma rays So as compared to cobalt-60 unit, these days we are using commonly LINAC, linear accelerator machine, which generate X-rays for the therapy. Advantage of this machine is we can on or off the X-rays, but this control was not disintegration of the gamma rays. Second advantage of LINAC is कर दे। So in LINAC, X-rays are of three types: ortho voltage, super voltage, or mega voltage. These are using up to 500 kV energy, 500 to 1000 more than 1 mega voltage. So out of these two voltages, mega or super, these are more commonly used. Why mega are more preferred than super voltage? In case of, suppose this is the skin and this is the tumor. If we are using ortho voltage, these are of low energy, they penetrate and they will deposit their energy near the skin. If we are using mega voltage, these are of high energy, they will penetrate the skin and will reach the tumor and deposit all their energy inside the tumor. So these ortho voltages which are of low energy, they deposit all their energy at the skin. So they are causing more skin damage. But they they cross the skin and they go to the tumor. So mega voltage, they are having skin sparing effect. They are having skin sparing effect. So if we are using such type of voltage X-rays which are having low energy and just beneath the skin they deposit all energy that may cause skin damage. But mega voltage they reach to the tumor and deposit all their energy inside the tumor. So they have skin sparing effect, means they cause less skin damage. So this is the advantage of using mega voltage over ortho voltage X-ray. Next is dose versus depth effect. This side is dose and this side depth. First is electron beam. This is the highest dose. Electron beam, if you are using, they deposit their energy at this depth. It means electron beam, they are near to surface. So for surface tumor, we can use electron beam because these electron beam, they deposit all their energy up to less depth near the surface of the skin. But proton beam, they come and form a peak and they fall to zero. This is the proton beam. Proton beam, they deposit their energy up to this depth. So they are more commonly used for deep-seated tumor. And this peak is called Bragg peak. This is called Bragg peak. So Bragg peak is associated with the proton beam. So they are superficial, they are used for superficial tumors, and proton beam are for the deep-seated tumor. And the last is our X-rays and gamma ray photon. They start here and they go like this: gamma and X-ray photon. It means these are having high entry dose and low exit dose. So this is the curve, dose versus depth. What this curve indicate that the electron beam deposits their energy up to this much depth. So if I draw Suppose this is the skin and this is the tumor, and one tumor is deep seated. So if you look at the graph, electron beam will come and end up to this depth. So electron beam therapy is for the superficial tumors, but the proton beam is for this depth. So this is more deeply seated tumor, so we can use for this proton beam therapy. And this is electron beam therapy. This is the difference. And the other X-rays, gamma rays, their curve is like this, having high entry dose and lower exit dose. If you are using this is the superficial tumor, and we can use the electron beam. So which periodic table element, they are pure electron beam emitter. So we call them pure beta emitter. Pure beta emitter. There are three. One is strontium 90, and one is phosphorus 30, and one is yttrium 90. So these three are pure electron beam or pure beta emitter, which are used for the superficial tumors. So up to now, what we have seen, our external beam or teletherapy, that was having using previously we were using cobalt 60, which was gamma emitter. Then we came with new technology, linear accelerator, which is having X-rays. And which X-rays are more beneficial? Mega voltage. Why? Because of skin sparing effect. Then two things, one is electron beam therapy and one was proton beam therapy. Proton beam. So these all are come under teletherapy. This is for superficial tumor, and this is for deep tumor like your brain tumors. Brain tumor. There is one more type of teletherapy, that is latest one, stereotactic radiotherapy. Stereotactic. It means these 2 points are important. Large dose of the radiation is deposited in a single fraction. So these 2 points are important for stereotactic radiotherapy. One is large dose and another is single fraction. So this stereotactic radiotherapy may be using gamma knife. Gamma knife is nothing but your cobalt 60. Cobalt 60. And one is called as cyber knife. Cyber knife. Cyber knife, we are using here X-rays, and they are produced by the machine linear accelerator. So in case of stereotactic radiotherapy, large dose is given but in a single fraction. Large dose, suppose there is 60 gray. So single fraction 60 gray is given as a 60 gray, not in divided form, single fraction. So that may be given with the help of gamma knife, that is cobalt 60, or with cyber knife, that is use of X-rays, and the machine is linear accelerator. So this was about teletherapy, and the next is brachytherapy, that is brachytherapy or internal beam radiotherapy. Brachytherapy, we can place the source of radiation on the surface. Then it is called plesotherapy. Plesotherapy. This is the terminology where if you keep the what we are using on the surface strontium 90. This is the radioisotope which we are using for the surface brachytherapy. Example is squamous cell carcinoma in case of cat, mast cell tumor in case of dog, equine sarcoid, which are periocular near the eyes. So in these, we are using surface brachytherapy, keeping the radioisotope near the surface of the tumor, and it will destroy the tumor cell. Important term is plesotherapy, and the important element is strontium 90. Or the second option is we can keep intracavitary. Intracavitary means you can keep in the uterus, lumen, or the cervix. Third may be interstitium. Interstitium brachytherapy. In case of BPH, in case of dog, this is the enlarged prostate, enlarged prostate, benign prostatic hyperplasia, or some prostatic tumor. Surgically, we keep the source inside the interstitium of the tumor. It will emit the radiation and it will kill the tumor cell. This is interstitial example. Next is systemic systemic brachytherapy, where we are injecting intravenously iodine 131. That is in case of thyroid tumor. So this iodine 131 is uptake, uptaken by the thyroid tumor, and it will kill the thyroid tumor cell. That is systemic by oral or injectable. So brachy means near, so it is kept near the body surface or inside the cavity. Then in case of brachytherapy, these implant, they can be used in two manners. Those radioisotope which are having long T half, long T half radioisotopes, they are used as temporary implant. They are used as temporary implant. For example, cobalt 60, it is having half-life of 5 years. Cesium 137 half-life of 30 years. So these are radioisotope, they have long half-life. So what we do, We keep these on the tumor, and after giving a particular dose, we remove. So this is known as temporary use of long half-life radioisotope for the temporary period. We just keep on the tumor. Once the appropriate adequate dose is given, we just remove and send the patient. Next day, again keep on the tumor, then remove. So this is how the long half-life radioisotope they are used as a temporary implant. These isotope they cannot be used as permanent implant. Question is why? Because suppose this is the animal which is having some benign tumor, some benign tumor. And if you keep a long half-life radioisotope inside the body and you forget it, and if the half-life of this radioisotope is uh, 5 years, then what will happen? This source radioisotope will keep on emitting the gamma rays and that will kill the benign tumor. With suppose within 30 days, it will kill the tumor. After this, what will happen? Half-life is 5 years. This radioisotope will keep on emitting radiation inside the body of the animal. The animal, it is treated from the benign tumor, but the animal will die because of this radioisotope, which is there for the 5 years. So, radioisotope with long half-life, we use them as a temporary implant. Just keeping for half an hour, 2 hours, remove, send the patient to home. Then next day use. Then if you keep a radioisotope inside which is having 5 years half-life, it will destroy the tumor and after that it will kill the animal. So we cannot use a long half-life radioisotope as a permanent implant. It will be used only as a temporary one. The second implant is radioisotope with short T half, short half-life. These are used as permanent implant. These can be used as a permanent implant. For example, iodine 125. The half-life of iodine 125 is multiply this 12 into 5. It is 60 days. It is 60 days. So you can keep this and forget your implant. After 60 days, tumor is removed and the implant is destroyed because of the spontaneous nuclear disintegration. It will be removed from the body. So iodine 125, there are two radioisotopes. So remember about iodine 125, which is 12 into 5, that is having 60 days half-life. It is used as temporary implant, not temporary. It is used as permanent. But iodine 131, the half-life is 8 days. This iodine 131 is used for systemic brachytherapy. We inject it for the removal of the thyroid metastasis. So iodine 125 uses permanent implant, but iodine 131 used for the injectable form for the thyroid metastasis. So this was about the radiotherapy, where I explained two types of radiotherapy. One was the uh, external beam radiotherapy, that is sources outside, and one is internal beam radiotherapy, that is the sources on the surface or it may be inside the lumen. One second. So radiotherapy, it was external beam or teletherapy, and it was brachytherapy. In this, I explained electromagnetic radiation or particulate radiation. In this, first we saw the old days cobalt 60 gamma rays emitter, then the modern days LINAC machine. You can control their energy and you can on or off the machine. Then particulate radiation, we saw electron therapy and proton therapy. This is for superficial and this is for deep. And one was stereotactic radiotherapy, in which we saw two things. One was gamma knife, and one was cyber knife. In brachytherapy, we saw first plesotherapy. Pleso, that was keeping on the surface like squamous cell carcinoma of cat. Then interstitial, that was prostate example, and systemic, systemic, that was iodine 131, and we saw the implant. Implant may be temporary or implant may be permanent. So this is all about the radiotherapy. Two types of. Then there are small some definitions or terminology in the radiotherapy. These are two terms. One is radio sensitizer and the second are radio protector. Radio sensitizer means was they will sensitize the cell to our radiotherapy. For example, hyperbaric oxygen, hyperthermia. Hyperthermia means heat. These two are radiosensitizer. Another is metronidazole. Metronidazole, it is also, and cisplatin, cisplatin 5-FU. Their main mechanism, all these drug, oxygen, heat, metronidazole, they help in generation of the more and more free radical. More free radical, it will kill the cell. Hyperbaric oxygen help in generation of oxygen free radicals. So they will make the tumor cell more sensitive by generating free radicals. Opposite to this, radio protector, they will protect. How they will protect? They are free radical scavenger. They remove the free radical. Only one example, remember amifostine. This is used as radio protector because it will remove all the free radical, scavenge the free radical, protect. And they generate the free radical, help the radiotherapy, kill the cell. A cell without, suppose this is the skin and it is developing a tumor. In this tumor, it is developing its own blood supply, but because of less blood supply, these cells they become hypoxic, and hypoxic cells are always radio resistant. Radio resistant. So to make them radiosensitive from outside, we can give oxygen, HBOT, hyperbaric oxygen therapy. So before starting the radiotherapy, we give oxygen therapy to the patient so that that oxygen help in generation of more free radicals, and it will sensitize the tumor and help our radiotherapy. So before taking a patient to the radiotherapy surgery, first we should give oxygen. And the good source of oxygen is water. So give water to the animal, and that will generate free radicals. Next is in ICAR 2017-18, continuously 2 year, one MCQ was asked from the that MCQ was most radio sensitive blood cell, and answer was lymphocyte. Lymphocyte. Why it is most radiosensitive? Because the lymphocyte contain large nucleus. It contains large nucleus that is susceptible. So remember this 2017-18 MCQ, most radiosensitive blood cell. Similarly, most radio resistant blood cell is platelet because it is without nucleus. If platelet is not given in answer, answer will be RBC. So these two are radio resistant. If both are given, platelet is the more correct. Then these were the cells. These were the cells. If they ask most radio sensitive tissue, not cell, tissue, then your answer will be bone marrow. Bone marrow. If they ask most radio resistant tissue, answer will be brain, your nervous tissue. Your nervous tissue. And if they ask MCQ from the cell cycle, this is the cell cycle G1, G2, here S, and there is M. The question will be most radio sensitive cell cycle phase out of this. So most radiosensitive is the G2M. This is G2, this is M, this G2M. And opposite to this, most radio resistant cell cycle phase is late S phase. Late S phase. So these are the important MCQs related with this. One more which is related with the this lymphocyte. The lymphocyte is itself most radiosensitive. So the tumor of the lymphocyte, for example lymphoma, and example multiple myeloma, which is nothing but a tumor of B lymphocyte. B lymphocyte. So these two tumors are radio sensitive because they are made up of a radiosensitive cell, lymphocyte. So lymphoma and multiple myeloma, your plasma cell tumor, B lymphocyte tumor is radio sensitive. Then There is one term, fractionation therapy. Fractionation therapy. One term is single dose and one is multiple or fraction dose. Fraction dose. Suppose you have total dose 60 gray. Single dose you can give 60 gray at once. But in case of animal radiotherapy, we use fraction dose therapy. Means the total dose 60 gray is divided into 12 fraction and one fraction equal to 5 gray. So 12 into 5, it is 60. So the total dose 60 is given in 5 fraction each, in 12 fraction, one fraction containing 5 gray. So 12 into 5, 60. And given 3 times a week. 3 times a week. So what is the advantage of using fraction dose instead of using single dose? Why fraction dose is? There is benefit. So the most important advantage is less chances of repair of tumor cell. Tumor cell. If you are giving fractionated therapy, then suppose you are giving 3 days in a week. If you are giving the therapy on Monday, Wednesday, or Thursday, then remaining days are Friday, Saturday, Sunday. Monday, Tuesday, no? Tuesday, Wednesday. In these 4 days, those normal cells which are also getting this radiation, they will recover. Normal cell will recover. But this tumor cell, they recover slowly than normal cell. It means within these 3 days, whatever your normal cell are also destroyed, they will multiply and repopulate. But the tumor cell in this small period, they will unable to recover. And after this, when you start your next fraction dose on next Monday, again these cells will be as compared to normal, they are weak, and the radiotherapy will kill these cells. So this is the advantage where there are less chances of repair of tumor cells. Means they are going to die. Then some side effect of radiotherapy. These are of two types. One is acute onset and one is late onset. Acute are most common is the skin erythema, means redness of the skin. This is more common. Second is epilation. That is loss of hair. Loss of hair. Hairs having hair follicle which is having multiplying cell. So radiation will destroy this. There will be loss of hair. Next is next is anemia because of bone marrow abnormalities, and next is because gonads are sensitive. So cases of infertility in male or female. There are two important acute side effects of radiotherapy, one in dog, one in cat. In case of dog, there is moist. In case of cat, there is dry. Dry or moist, what is desquamation, shedding of the skin, desquamation of the skin. Here moist and here dry in case of. So these are acute side effects, and there are only three late effect. One is cancer, leukemia. One is related to your eye, cataract, and third is shortening of the lifespan of your animal. This was asked in Punjab PSC VO exam 2019. The late side effect of radiotherapy, leukemia. There are some important T half of the radioisotope. One there are in one exam they have asked. So remember, yttrium 90, it is having 2 days half-life. How to remember this? If you start the A B C D Y and Z, count from the back side, it is at number 2. So 2 days. After this, iodine 131. This is of 8 days. Then we have iodine 125. How to calculate this? Separate this 12 and 5. 12 into 5. It is 60 days. Then cesium 137. It is 30 years. Cesium 137 is 30 years. It was asked in one PSC exam. Cesium 30 years. Then cobalt 60. That is your 5 years half-life. Most important. Cobalt 60. Not only cesium, the strontium 90, which we are using in electron therapy, that is also having half-life of 30 years. And one more radioisotope which is used in the nuclear medicine, scintigraphy, that is technetium 99M, M for metastable isotope, technetium 99M, used in nuclear medicine, or it is called scintigraphy. At the end of the lecture, there are 6 hours of radiotherapy. There are 6 hours of the radiotherapy. How to these? The trick is your clinic's OPD. So first O will help you reoxygenation. Re is common. This is common. Reoxygenation. P is repair. Repair. And again P is repopulation. Repopulation. And D is redistribution. Redistribution. These are for number 5, number 6. Number 5 is radio sensitivity. Radio sensitivity. And the 6th, which is the latest one, it is the reactivation of immune system. Reactivation of immune response, not immune system. Reactivation of immune response. So these are the 6 R of radiotherapy. That is deoxygenation, pair, population, D for distribution. Number fifth is radiosensitivity, and the latest one is reactivation of the immune response.